Everyone, welcome to our monthly grand rounds, and it's a real honor today to have Dr. Arai visiting us from Utah. Dr. Arai and I have known each other probably 10 years now, but he's been a force in the field of cardiac MRI and cardiac imaging. He did his MD from UIC in Chicago in 1986, received his BA from Cornell in Ithaca in 1982, went on to do medicine residency at Oregon and his fellowship at the same place, and then moved to the NIH, where he ran the program from 1994 to 2021. We were just talking earlier, his work in cardiac perfusion and all the work he did while he was at MRI has really transformed the field, moved it forward, and brought cardiac MRI as a clinical modality in day-to-day use. And so he deserves a lot of credit for making that transformation. And he's served in many leadership roles. He was, in 2001, he received the Presidential Early Career Award for Scientists and Engineers. While at NIH, he had more than $79 million in NIH funding over the years. He's trained about 70 cardiologists and radiologists who are scattered across the country running their own successful programs. He's had over 300 papers and book chapters. He's been a member of the American Society of Clinical Investigation, president of the Society for Cardiovascular MR. So when you see MSCMR, that means Master of SCMR. I'm just an FSCMR. He's been an expert advisor to the US FDA. And really, most of you who read about cardiac MRIs in our group have heard and read his work on things like area at risk in myocardial injury. That was his concept on T2 imaging and mapping, really working through the nuts and bolts of making sure these techniques are correct in preclinical models and can be applied to human models. Diffusion, tensor imaging, I could just go on and on. His contributions to MR are really exemplary. But he's really a methodical, scientific, careful thinker, and people really appreciate the depth and gravitas he brings to this field. So, Dr. Arai, it's such an honor to have you here with us, and really excited to hear your talk. Thank you.
Well, that is a really kind and generous introduction. So thank you. I should also say that this isn't one person. This is really what team science can do. And MRI is a particularly fruitful environment for that because MRI scanners are reprogrammable. Very few researchers can reprogram a CT scanner or an echocardiogram machine. Few can, but not very many in the country. Almost all high-level universities doing MRI research have physicists that can reprogram scanners, and you can translate it to patients quickly. And frequently, things are 5 to 10 years ahead of what industry has. Anyway, this is a picture of the University of Utah. We're on the foothills, 800 feet over downtown Salt Lake City. It's a beautiful environment. When it rained last weekend, there was snow on tops of the foothills. These are my disclosures. My goals for this talk are to cover a few things. Why we should do myocardial perfusion imaging at all, how we quantify myocardial perfusion, really talking mostly about PET and CMR, and a little bit of comparative effectiveness at the end, or accuracy studies. So this is fundamentally one of the reasons why perfusion imaging is so important in coronary artery disease. And that if you start at the bottom of the slide, the axis is time. And so a perfusion defect is the start of ischemia. And and I should credit, this came from an ACC slide. I forgot where the reference came from, but you'll see this in a lot of basic talks. And some of the first things that happen after a perfusion defect are metabolic abnormalities, diastolic and systolic abnormalities. I'm pretty sure systolic and diastolic go at the same time based on work I did in Oregon, but the dogma is diastolic first. Then the LV wall motion abnormalities that you can see by echo. All of this typically will happen before EKG or chest pain. And that's been proven in the cath lab by people timing things when they inflated a balloon. So a total occlusion of an LAD. All these things happen before EKG changes in symptoms. And if you go over that 15-minute threshold in dogs, maybe 20 to 30 minutes, you start to infarct the myocardium. But it all starts with perfusion, and perfusion is really key. I'll start with PET, mostly because PET is what taught me a lot about why perfusion is important and how to quantify it. And we'll start with a simple case. This is a 65-year-old male with extreme obesity, BMI of 53, dyspnea on exertion, sleep apnea, diabetes, supposedly previously had non-obstructive CAD and was referred for a stress PET and quantitative flow. This is what PET scan rubidium PET looks like at the University of Utah. On the maps, there are two borderline abnormalities. So some stress score of 2, which they consider nonspecific, and most likely not having epicardial coronary disease. This is what the quantification looks like. And if you start in the top left, and these curves look pretty similar to what we see by MRI. They get a series of images over about 25 minutes, I believe it is. Maybe is it slightly different? No, these are frames. But the bottom line is it's a slower temporal resolution than MRI, but the curves look pretty similar. And if you look at the numbers overall, there's no regional variation supporting the diagnosis that it wasn't coronary disease. But the flow reserve is in the 1.4 to 1.6 range, should be close to 2, 1.9 or so. So this patient has a diffuse microvascular disease that is important. Part of the reason I took this case is that there are very few, at least AHA level guidelines for quantitative PET or quantitative MR, except for microvascular disease. Because it's not generally regional, you can't rely on regional variations like you can see on a SPECT scan. All right, concept number 2 is if you start in, this is really old work from like the 1986 to 1995 time period. Quantitative PET's been around that long. But if you look at resting blood flow, and the x-axis here is percent stenosis in the coronary artery. Resting flow stays, and you should all know this from basic physiology, but does not change until you really get into a critical flow. Break points around an 80%er, but to get beyond the error limits, it's really about an 85% stenosis before you start seeing rest perfusion abnormalities. And this is fundamentally why we do stress tests, that we need to raise the metabolic need of the heart. Blood flow has to go up and does go up nicely. A 3 or 4-fold increase is a normal response. There's a lot of variation in it. If you have a 50% stenosis, most of your CT reports are talking about obstructive coronary disease. It's not obstructive in most patients by FFR, PET, or quantitative MR. I think we have bad terminology in the field. But some stenoses in the 50% range will be significant, particularly if they're long stenosis or various other complicating factors. When you hit a 70% stenosis, the great majority, but about a third of stenoses in the 50 to 70% range will cause ischemia, and about 2/3 to 80% or so. Anything over about 85 or 90%, most of those should be ischemic. Early PET study by Marcel DeCarli, one of the real PET experts, is some of the early data that was pointing again that a myocardial flow reserve or myocardial perfusion reserve around 2.0, some people use 1.9, is a pretty good cutoff for significant stenoses, and that may be true by MR as well. And again, it corresponds mostly to the break point between the 50 to 70s and the 79 70 to 90% stenoses. Now, when we start talking technically about PET, we tend to think of these tests as gold standards. That's the way experts like to talk about their own technology. So slap me if I pretend to be like that on the MR side of this. But there's only one PET tracer that's supposedly nearly ideal at 015 water, and it's, as I'll tell you later, not FDA approved. But there's a linear relationship between blood flow and uptake of 015 water during these stress tests. Anything that curves lower tells you that you can't see a change in blood flow. If you look at the bottom of the axis here, this is a 20% change in blood flow. But I can tell you, our SPECT tracers at the bottom here, thallium to sestimibine, they're not going up 20% over this time span. They're going up 4 or 5%. And what degree stenosis do you want to, or what degree FFR do you want to detect? FFR of 0.8, right? Or 0.75 if you're more strict. But you can barely see a signal intensity change with the SPECT tracers in this range. If we don't get as good a flow reserve, maybe you're a little more sensitive. But there's a fundamental issue with our most common stress test in detecting stenoses. The PET tracers in that range are much better. They still drop off a little, but they have the advantage that they can be quantified and they can get rid of this nonlinearity. Now, another technical thing about PET is we're used to thinking about a radionuclide, and we're told, oh, radiation's coming out from where the tracer is. PET's weird. It's got something called a positron range. So if this is where the radionuclide is, it will break, and there will be this movement of the positron before it then annihilates into 2 photons. So this distance gives you an uncertainty of where it came from. And if you look at rubidium, that uncertainty is 8.6 millimeters. That's almost the thickness of a normal left ventricular myocardial wall. This is a blur factor in rubidium PET. If you look at 015 water, it's about half the blur. Ammonia goes down another, that should, I think, be 2 millimeters. Sorry, ignore those 4s. Flupyridas is down to 1 millimeter. But the bottom line is that little dot is a lot sharper and more precise location of where the perfusion information is than rubidium. And rubidium is our #1 PET agent that we use clinically. So there's a review invited by Jack Imaging that's sort of available online at the pre-press stage. It's accepted. I wouldn't read it now. It's not formatted nicely yet. But there are some tables in here, and there's some interesting factors. So if you're looking at things that are, I think, problems for various agents, I put these red stars up. So ammonia and 015 water require an on-site cyclotron. Those are extremely expensive devices. I could not afford at NIH to do PET studies because every PET cardiac study that I do would cost me $3,000, whether the patient showed up or not. The 015 water has an even bigger barrier. It's not FDA approved. Intermediate issues, rubidium, again, 4 positron range, so the blur factor, and a closest to the highest doses of radiation. But there are a lot of good things. The stars, I think, are factors that favor various agents. So rubidium, you don't need a cyclotron. You can buy a generator, but they're fairly expensive. They last about 6 to 8 weeks. You can do close to an indefinite number of cases during that time period. But so they work well if you're a high volume center. They're expensive if you don't do enough cases. Flupyridas, this new agent, has a lot of things going in its favor. It can be made at a regional, like at Salt Lake City, there could be a cyclotron and they could serve PET air centers around the area. And so you don't need to afford the cyclotron. However, they made it extremely expensive. So I don't know how their business model will work either, but we'll see. We have tables in this review that look at some of the other technical aspects. So for PET, you're really looking at an imaging level of resolutions of about 5 to 7 millimeters and a temporal resolution of every 5 to 10 seconds. MR is like 1.5 by 1.5 by 8 millimeters. We can do every heartbeat imaging up to a heart rate of 120. You saw the extraction fractions for the PET agents. MR or gadolinium and CT contrast is in the worst possible range. This intermediate to low 40% extraction, and that takes modeling to take care of it. We won't go through the rest of those factors, but it's easy to say that the physics of PET perfusion are simpler than MR perfusion, although similar. So here's another case. This is actually a published Marcelo DiCarli case, 74-year-old man with known CAD and a prior PCI with recurrent chest pain. He underwent SPECT imaging, 10 minutes on a Bruce protocol, pretty good. Heart rate 58 at rest, 134 up stress, 92% of predicted. Blood pressure wasn't hypertensive. Good rate pressure product, had chest pain, had EKG changes, 2.5 millimeters in inferior leads and V3 through V6, which resolved 11 minutes. Sure sounds like a positive stress test. And here are SPECT images. They look normal. We miss things by SPECT, and yet we do 6 million of these right now every year. Almost free ECG got the right answer there. So I truly, strongly believe that PET perfusion should be replacing almost all the SPECT in this country. And if you can't replace it with PET, MR is going to be the other competitor. And CT, of course, is taking a lot of that role. But I think it is time to move forward. And like I said, guidelines right now say microvascular disease for quantification, but I believe quantification also helps with coronary disease. I think what I'm going to do to stay on schedule, I'm just going to skip this one. So what about prognosis? There's a limit to how much I can show. And I wanted to say that, one of the strong things about PET is that there are now large studies, 5,000 patients more, long-term outcomes. A lot of this coming out of the Brigham and Women's Hospital and Marcelo DiCarli, but other groups as well. And you look at mortality, so a hard cardiovascular outcome predicted by various severities from a reference normal to mild, moderate, and severe on PET scans. And you just see a graded worse prognosis. And it doesn't matter so much if you do it by unadjusted or adjusted analyses. The bottom line is PET is a very good predictor of long-term outcomes. We're not going to talk about CT. Hopefully, I wonder if he got the wrong, I hope he doesn't have the wrong slide deck. This is not the right slide deck. Desktop. Yeah.
Get off of this and just see if you put it on the.
We have the computer here. I was going to talk about CT, but then I'd be 20 minutes over. So the short story, while we're trying to take care of presentations. Should have done that instead of eating lunch. You can quantify perfusion by both PET and echo. There's a fair amount of literature on that. But their normal values don't really correspond with PET and MR. Their radiation doses for CT are very high. And the echo data is the weakest of any of the modalities. It can be done in the hands of experts.
Presentation is that
The top one.
quantitative? That
Yeah.
one there.
Yeah, this one.
The one we have on the desktop.
Well, let's see if we can pull it up here. Maybe I copied the wrong one. Hope not. We'll see if there's CT slides. Well, we're going to go here. Sorry about that. All right. So kind of a clumsy segue to stress perfusion MR. Yep. There we go. So this is how you do a non-quantitative stress perfusion MR. Basically, it is possible to do this in 30 minutes in some centers around the country. Very few are the world. But you could do localizers to find the heart. You could start with stress perfusion. That takes a few minutes to run, go through your cines, and finish up with late enhancement, thinking that you just substitute rest perfusion with a much better way of looking for infarct or scar late enhancement. So this is sort of the minimalist approach. You could do this quantitatively as well, because all the sequences now are pretty much equivalent in time. But this is what we think as a field people should be aiming for. In many respects, less is better than more. We cannot afford the duration of cardiac MR scans now. It's one of the things that holds the field back. So more efficient protocols are important. So I already mentioned that virtually the same images that we use in qualitative interpretation of stress perfusion MR can be adjusted with a relatively minor programming difference. It took 10 years to figure out how to do it. But once they figured it out, it's now automated. And that involves detecting what we call the arterial input function, or the AIF. This is essentially the delivery of contrast to the heart. And then we have to image every heartbeat as the contrast comes into the myocardium and washes through. And so we get time intensity curves. And I told you these look a lot like the PET curves. And you can see the difference between rest and stress. And during stress, things go through more quickly. So the slope's up and it washes out more quickly than at rest. So the bottom line is we can use pretty much the same physics for interpreting time signal intensity curves after they've been converted to concentration units as the PET community uses for quantifying PET scans. There's fundamentally one difference. We're truly doing first pass perfusion. PET isn't fast enough to do first pass perfusion. So a lot of their information comes out from the washout phase. But the same things are going on in the physics of clearance of the contrast agents or tracers. And so the physics of the actual quantification and many of the models are the same. And we can now, because of motion correction techniques, and a lot of this came out of our lab at the NIH, you register, we actually don't do the stress during a breath hold. We let them free breathe. And so there's shallow movement up and down, and that's mild enough that computer programs can line up the pixels or the images pretty much down to the pixel level. And these are much higher resolution than PET scans. If we had people hold their breath, people would inevitably need to breathe at about 15, particularly patients, 15 to 20 seconds in, right when the contrast arrived, and screw up the ability to quantify these studies. So free breathing and motion correction. Videos of stress perfusion look like. Starts out dark, and you can see RV, LV, and then the myocardium is a blush. RV, LV, and then the myocardium is a blush. And this patient, I don't know if we can go to the next page. You also get, obviously, high-quality cines. You get late gadolinium enhancement. This patient looks like he has a thick wall and a sort of a diffuse fibrosis. Looks like hypertrophic cardiomyopathy. And we can interpret it pretty much the way you interpret an echo. For wall thickness, regional wall motion, you can interpret the LGE in terms of fibrosis versus myocardial infarction. You can look at the stress perfusion qualitatively. You could read a study like this if you had efficient software in probably 10 or 15 minutes. I don't think our software is that efficient, and my brain isn't quite that efficient, but I'm slower than some of the other readers. But anyway, so pretty good study. But why? One of the things that really put cardiac MR on the map wasn't perfusion imaging, and it wasn't cine imaging. A lot of people bet on cine imaging, but it just isn't good enough to replace echo, and it's too expensive. It is better than echo most of the time, but that doesn't change the field. Late gadolinium enhancement, on the other hand, was the first positive sign of infarct that made a difference in medicine. Pyrophosphate scans could pick up on infarcts as a positive abnormality, but that technology never moved forward. But we can see myocardial infarction. And what caught people's attention, this is work from Ray Kim many years ago. This is an animal heart. TTC stained. Red is healthy myocardium. The pale area is infarcted. Look at the image right next to it. The detail down to square millimeters between what's infarcted and what's normal is pretty close to 1-to-1. You can go at any level, like over here, look, these little fingers. You can see them on an MR image. Now, these are ex vivo images, higher resolution than we can do in people. But the bottom line is this put MR on the map. Let's see here. So does that resolution actually make a difference? We diagnose MIs all the time, right? Well, there were 2 studies that came out early on comparing with SPECT and one with PET. I've only got this one example, but here's a normal SPECT scan, and here's what the MR looked like. SPECT missed this infralateral infarct that extended all the way out to the apex. Binary decision, normal versus abnormal. Prognosis should be good, prognosis should be poor. It's a binary problem. SPECT does not have the resolution to pick up what MR can with LGE. I put this slide in, we tend to read a lot of stress tests as negative, and we're saying negative for coronary artery disease. When you read a stress perfusion MR, a lot of times the late gadolinium enhancement gives you a positive diagnosis of something else. Like in this case, here's an abnormality at the apex, in the interventricular septum, and in the right ventricular wall. This is cardiac sarcoidosis, multifocal regions. Very few diseases will cause that. Down below it, here you can see an epicardial pattern of enhancement with a few areas that are more transmural. Myocarditis. Myocarditis is an explanation for about 30 or 40% of Minoca. So we see people at the U all the time come in, troponin positive, chest pain positive, go to the cath lab, coronaries are clean, the echo's normal, and I say, get an MR. MR will give you an answer in 2/3 of those patients. So a positive diagnosis of a non-ischemic process. what's a problem that you've heard about in SPECT imaging? Balanced ischemia. So does MR have a problem, the same kind of problem with balanced ischemia? And the answer is no. And the reason is that you have the transmural, the ability to image perfusion across the entire wall. So you can tell if something's got a subendocardial severe defect and less severe on the epicardium, as opposed to just a diffuse abnormality. And so here it's pretty obvious. There's all these dark areas in the myocardium, and the SPECT is normal. So nothing was FDA approved, and none of the companies wanted to invest in doing a study. We worked with Bayer, 4 past presidents of SCMR, pretty much strong-armed Bayer to fund a clinical trial to get FDA approval for some gadolinium contrast agent. Obviously, Bayer bought in, and so Bayer got. But anyway, in an international multi-center trial to get high-level results like this impressed me that this is technology that's workable. So again, here's the strength of LGE. The cine's not a movie, but you can see an anterior and an inferior. These are tiny infarcts. Both of those are sub-gram in that slice, and yet they correspond to perfusion defects, detectable by stress perfusion MR at a qualitative level. And that's a pretty good area under the curve. I don't know if I have the SPECT curve, but it was lower. What about clinical trials? Ike Nagel ran a very impressive study of stress perfusion MR, randomized controlled, and basically 900 plus patients. There were 2 arms. One was informed by invasive FFR, the second MR informed based on stress perfusion. Everyone got an MR. Half of them were like blinded to the researchers. And if the FFR was positive or they had a greater than 95% stenosis, they were recommended get revascularization and optical medical therapy. If not, they were randomized to optimal medical therapy. Same kind of idea by MR. I hope I have the next slide in here. So when I first saw these results, I said, oh shit, excuse me. MR didn't pick up on enough. So MR positive, 40%, so less than half the slice. FFR said 61% were positive. If MR is missing that high a percent of significant coronary disease, potentially we're in trouble. So really the outcomes become critical. And here's New England Journal of Medicine. They love these inserts. If you look at the top curve, this is really the prognosis difference. I can't remember what, I guess FFR is in orange and MR is in blue. They have a really good prognosis. Even when you blow it up at high scale, these are pretty much superimposed over each other. In other words, MR picks up on less defects, but not in the people that actually probably need something done beyond medical therapy. Very impressive study. I would not have had the guts to do a study like that. And what about prognosis? One of our friends, Raymond Kwong, has done a whole series of prognosis studies out of something he called the SPINS registry. And now we're both participants in the SPINS 2 registry. We were both participants, I think, in SPINS itself. But one of his major findings was if you had a normal scan, so stress perfusion is normal and late gadolinium enhancement is normal, the primary outcome of cardiovascular death, less than 0.6% per year. These are annualized rates, I believe. If you have LGE but no ischemia, it goes up or ischemia, but no LGE, you sort of have this intermediate range. But if both LGE and ischemia are positive, the event rates go up even further. So you can see a graded response based on the abnormalities, and infarct imaging and perfusion imaging are complementary and additive. All right, let's look at quantifying blood flow. So this is a swine study at NIH. How are we doing on time? Great. So anyway, so these pigs, we put an occluder around the proximal LAD, and it was hooked up to a syringe pump that could regulate the pressure in the LAD. And we had a catheter distal to the occluder so we could continuously measure fractional flow reserve, a pressure difference across that stenosis. And we could dial in what degree of stenosis we wanted. So this is 3 different MRI methods. The top was one that my scientist, Li Wei Su, came up with. The middle one was what Circle actually licensed the software from the NIH, but their method used his software. They'd made a few refinements. And you can see they agree pretty well. And the bottom row was Peter Kelman's method that looks a little bit more severe than what we saw in these. But if you look at these plots, what these plot is on x-axis is invasive fractional flow reserve, as I mentioned, continuous. And so it's simultaneous with the MR perfusion. We did our microspheres immediately after the stress perfusion injection was done. We didn't want to disturb the primary experiment. But the bottom line is invasive flow reserve on the bottom axis, and a perfusion blood flow ratio between the normal and the ischemic zone. And you can see almost all the points by all 3 of these methods are in the white zone for both abnormal, both normal statistics, highly supportive of being able to pick up on fractional flow reserve abnormalities. This is the human study that came out, actually probably before the animal study was finally published. I actually delayed this paper by about 6 months because of this graph here. So clearly we could see significant CAD, this is by QCA, as abnormal and different, clearly statistically highly different than the remote zone. And the patients with no CAD, their blood flows were maybe slightly higher, but not statistically different. But the bottom line is, when we looked at myocardial perfusion reserves and total flows, I was shocked to see people with no CAD having these relatively low blood flows, and relatively low, too close to 2.0 for flow reserve. Now, these are all people referred for stress tests. Like I said, I delayed the study for 6 months to get a whole series of normal volunteers just to verify that our methods could actually quantify higher blood flows. And so one lesson from this is that most patients that are referred to us for stress tests have a component of microvascular disease. Most patients with coronary artery disease, yes, they have regional disease, but their other vessel parts of the heart are probably affected by microvascular disease. And if you look at the area under the curve for sensitivity specificity, obviously these had quite reasonable diagnostic accuracy statistics. And then here's beauty of the maps. Yes, you can probably see a dark rim here. And this is one of the big weak links in MR that a lot of times we see something we call the dark rim artifact. But it's hard to have an MR specialist look at this and not say there's diffuse subendocardial perfusion abnormalities. But when you quantify this slice and you see that it's up in the close to 3 ml per minute per gram of tissue, that's got to be an artifact. And so the quantification, I think, can solve one of the big problems that we have in MR these dark rim artifacts. And we were at a quantitative perfusion seminar 2 years ago, and I had Sven Plein, one of the world experts in quantitative perfusion, next to me, and I had loaded this study up, and one of the people in the audience said, "Which is stress and which is rest?" And we both looked at it. These were pretty crappy images, not from a Siemens site. I won't say which scanner, but we couldn't really tell looking at the movies or the raw images. And I finally asked the audience to vote. It was a table this size. It was like very close to 50-50. I said, let's put on the easy button and then turn on the color maps. And it was orange versus green. And so the bottom line is being able to see that there was a flow reserve is pretty close to instantaneous. Now, if you look at single vessel disease, this is what an inferior perfusion defect looks like. There's something really interesting if you look at this med slice. So obviously remote myocardium's got a good flow. It's up in the orange range. The green was what it started with at rest, right? Look at that. Inside the perfusion defect, there's a dark area. There's actually steel going on within the perfusion defect and lower than rest perfusion in the core of that perfusion defect. That's a very highly specific sign in my experience for a severe perfusion defect. And that would be hard. I mean, I don't think anyone would miss this perfusion scan on the raw data, but to see the detail of the extra information like this, actually a perfusion steel within the infarct or the perfusion defect is interesting. And then what about global ischemia? Can we see that? You know, if you just looked at green to green, you might say, I'm not sure. If some part of the heart gets into the orange, you have a very good sense that you had a good perfusion defect. In a more severe area, like at the midventricular area, yes, there's a little bit of orange. It's not nearly as intense here, but it's much more severe in the inner linings. So we call this the gradient of perfusion across the wall. Amadeo Kiribiri at King's College has published several papers on it. And so when you see worse endocardial blood flow than epicardial blood flow, it's highly specific for ischemia. So anyway, so bottom line is that's one of the big benefits of the resolution of MR perfusion scans. Simple slide, it works in obese people. I can't remember how big the people were, but I know we've scanned at NIH people that I had many years ago. I don't know if people remember the old TV show, The Biggest Loser. We had 5 patients or 6 patients that could have qualified for The Biggest Loser. In fact, their average weight was higher than that season's Biggest Losers. And they fit in MR scanners, and you could do perfusion in them. And Raymond has shown that we have prognostic value in those patients. What about low EF? I was worried that low EF might be hard to quantify. In fact, sometimes it is. And that's one of the things you need to look at on the curves, that if you don't have enough of the arterial input function to define the tail end of, you shouldn't trust those perfusion numbers. But the bottom line is stress perfusion MR works quite well with low EFs, but I think there's a lot less experience in people with more normal hearts.
You still expect to see the endocardial, epicardial gradient to the same degree in low EF? Probably not, right?
Well, one of the problems, a lot of low EF people have what we always used to call the dilated cardiomyopathy, thin walls, big cavities. So whether we still have the resolution, I think the King's College sequence may still be able to, but it's a good question. And then, you know, for years, people would say, what I charged for cardiac MR and CT at the NIH, and I said, I give this away for free. We had to take people in on research protocols. We had no mechanism to take payments. The rest of the world, on the other hand, has to make a living, all of you included. And so this is an analysis of whether CMR could be cost effective. And the bottom line is in almost all parts of the world, stress perfusion MR can be cost effective. It's a little in the gray zone for the US, but it's still considered in the range where it should be cost effective. All right, couple of slides to finish up on diagnostic accuracy. This is a meta-analysis from Eccles group and Circ Cardiovascular Imaging from 2015. The reference standard here is invasive FFR. There are actually very few echo studies. In fact, the European guidelines don't publish FFR data for stress echo. They found 177 patients that could fit. But if you look at SPECT and echo, they're not the 85% sensitivity and specificity that I was taught that those techniques run at. And you have to remember, there haven't been validation studies of stress echo since about the 2000s. Echo was a whole lot different. The quality of studies at the time was a whole lot different too. A lot of these studies are felt to have been inflated by what's called referral bias. So if you have a very enriched group of patients, the chances of having good sensitivity and specificity go up. But anyway, bottom line is in the studies that are available since invasive FFR, SPECT runs at a sensitivity of about 0.74 and a specificity of 0.79. Echo, lower sensitivity, 0.69, but very higher specificity. MR and PET are in the mid to high 80s. CT is in the high 80s for sensitivity until you do something like fractional or CT-FFR or a physiologic test. The specificity is a little lower. 50% stenosis by CT looks pretty alarming, particularly when you read a stack of 9 normals and then, whoa, look at this one. But the bottom line is those are the 3 technologies I like the best: quantitative PET, quantitative MR, and CCTA. And these are the comparative receiver operator curves. SPECT is in orange. Best AUC is going to be one that comes up as close to the upper left-hand corner. SPECT and what color is this? This should be echo. Yeah. They're clearly operating at a different range when you look at meta-analyses. And CTA, quantitative PET, and qualitative MR behave at a higher level. The right side of this slide is kind of interesting. What this is, on the x-axis, they plot pre-test probability of disease. And on the y-axis, they plot post-test probability of disease. And the dashed line is if you, at any probability, if you didn't change things, so if there was a 10% pre-test probability of disease, you'd get a 10% a post-test probability of disease. In other words, your test made no difference at all. The best test, if positive, is going to raise you up, and if negative, is going to push things down. And so the tests that work the best are the ones that are out in the extremes of these 2 curves. Well, again, stress echo and stress and SPECT are in the inner curves. They don't push you as high up for a positive diagnosis and don't push you as down or reassure you as much with the negative. Whereas CT or MR, stress perfusion, MR, and PET both push things up well. And they're superimposed down here. CT is the interesting one, though. CT doesn't push things positively as much, but it is the single most effective test for ruling out coronary disease. And that's why it should be used in so many of our younger patients presenting with chest pain initially. Okay, so this is another table or part of a table out of this review that's coming up. So this summarizes all the normal values that we could find for PET, for ammonia, rubidium, water, and flurpiridaz, all of 7 patients so far, and MR at the bottom. And you can see our numbers now are actually pretty close to what the PET literature says. Resting blood flow varies a little bit, but basically 0.71 to 0.87 for PET. For MR, it's a little bit higher, 0.95. For stress values, about from 2.53 to 3.44. So more scatter on stress measures. MR is sort of in the middle there, 3.29. And you can see coefficients of variation are on the same order of magnitude for MR versus PET. And for myocardial flow reserve, MR is clearly within the range of what PET can do. So bottom line is, it's still kind of messy literature, both on the PET and MR side, but at least they're kind of comparable. Close to the end. So what did the guidelines say? These are the 2021 guidelines. I saw last night there's another guideline. I'm going to have to reread that. But bottom line is, the 2021 guidelines were a really big step forward. And really, they put CCTA in a primary role as an early test for coronary disease. And that, I think, is very appropriate. They went a little bit too far in one draft, but the bottom line is I think they got a good balance. They weight stress imaging all as a lump. So it doesn't matter what modality, they consider it all the same. And it's appropriate. And most of the indications, either CTA or stress testing is appropriate for intermediate risk, not the ACS range, whatever. But there's definitely also advice to use CCTA in the younger people and people that don't have a lot of calcium, and favor stress testing more in older people and higher pretest probability of disease. And from a quantitative perfusion, there are only two of the indications. PET gets on both of those. But it's really, again, this microvascular disease that the guideline writers thought is the one area where quantification has a difference over tests that look for regional variation. And since epicardial coronary disease is still what most cardiologists think we're looking for, that's where it fits. But as I've been trying to tell you in some of the prior slides, I believe almost everyone with coronary disease, it's not just in the epicardial vessels, it's more diffuse. And then the real bugaboo, is stress perfusion MR really practical or feasible? And I have to agree, despite all our efforts, it's kind of marginal in most parts of the world. One of my past fellows runs an MR program in Beijing, in the single biggest cardiovascular hospital in the country. 4 MRI scanners. Each scanner does 5,000 MRIs per year. 80% of those are cardiac. 20% is other stuff. When I was there, we were there for giving a quantitative perfusion course for radiologists. Cardiologists don't do MR in China yet. So my past fellow, professor now, ran a quantitative ATP. They don't have adenosine. They can't afford regadenosin, but they can't afford MR scanners. 27 minutes. 27 minutes. This patient had hypertrophic cardiomyopathy, visually obvious perfusion defects. Color maps popped up on the Siemens scanner just off the top. Anyway, pretty darned impressive. And then the other site that's really done a lot is Raymond Kwong at the Brigham and Women's Hospital. And he's been working with a company called Vista AI. And Vista AI is a AI-based software that can replace many of the functions of the MR technologist. But the real things they ran into, they were able to reduce scan time, but not all that much, maybe from an hour to 45 minutes or less than 45 minutes. But the biggest thing was that they reduced scan time variability. And what that means is schedulers could actually schedule shorter blocks. The worst thing is an imaging schedule needs is one person to run 30 or 45 minutes over their allotted time. That screws up every patient in the rest of the day and just causes haywire. So they'd rather do fewer patients than screw up their schedule. So getting rid of scan time variability was a major part of this. They reduced the wait time for an I guess, an MR scan, just this general MR, from 28 days to 1 to 2 days. Talk about a physician. You want to know something wrong with the heart. How many cardiologists really want to sit for 28 days wondering what the answer is? I'm seeing if they can still remember which patient that was. 1 to 2 days is what cardiologists think about. You know, in the hospital, you're talking hours, not days. So the bottom line is wait time is a huge issue. And I think technology like this can make a huge difference. There are still challenges. Told you a lot of positive things here. I think flurpiridaz may really be a good answer. I don't know if it's priced right for that, though. No FDA approval for quantitative MR perfusions, research sequences still. Despite that, Medicare has a T code for doing quantitative perfusion. So all of your Medicare stress perfusion studies, Medicare will pay like $700, I think, for a stress perfusion MR. If you do it with this research quantitative perfusion sequence, they'll add $1,500, kind of like CCTA and HeartFlow several years ago, same kind of process. So they're looking to see if this technology works. So you guys should be doing as many, and you guys have the sequence from King's College. You probably just need to get institutional approval to use it. I think normal values are still a problem. I think regadenoson, I didn't talk about this. Everyone wants the easy button. And regadenoson, there's no easier way to do stress perfusion, and I agree with that. In fact, you get probably a better stress test because you not only get vasodilation, but a heart rate response. But if you do your rest perfusion after regadenoson, you don't get a good rest, and that screws up your perfusion reserve, and that screws up one of your powerful prognosticators, and the field's still struggling to figure out how to deal with that. I'll stop there and see if there are any questions.
What is the idea of using adenosine, especially for spins too? But we've been using an awful one after plexus scans. What are you doing?
So we looked at that, and Amit Patel published that, in our experience, if we did quantitative stress perfusion first, gave everyone aminophylline, waited full 20 minutes. That's a long time after stress. A lot of people want to do it within 10 minutes. At 20 minutes post-stress and probably 18 minutes post-aminophylline, their post-stress blood flow, 25% higher than the rest. We sort of discovered that in our normal volunteers and actually brought all those normal volunteers back for a rest and stress study with the order reversed. And that's how we were confident that there was a 25% difference. So the bottom line is, starting when you're looking at flow reserve, dividing by, say, 1 is normal, that's pretty much what your rest or your stress flow is. It doesn't change the ratio. But if you divide by 1.5 or 1.25, you're going to erode your flow reserve by that kind of factor. And you'll take people that truly had normal physiology and mislabel them as having microvascular disease. And that is the biggest thing the guidelines have identified as what you should be looking for or get out of this technology. So I think it is a big problem. So the other way to try to do it is to do rest perfusion first and follow it with stress. We do that on our quantitative research studies at Utah, and the quantitation can get blood flows. The big question is whether we can qualitatively still see real perfusion defects, and I don't have enough experience to know that. Almost no one's happy about doing rest first by MR. And Bayer points out that they're FDA approved for stress first, followed by rest. So again, you sort of breaking your FDA, but we do that all the time.
Mine's more about the clinical workflow. So if we find a patient on a CTA that has an intermediate grade lesion, do you think we should be leaning more on CPFFR or just sending them for stress CMR to determine significance?
So I only have a year and a half experience with heart flow, and that was another thing I didn't want to pay for at NIH. So I just don't have enough experience to have seen problems. What do you think, Dinesh?
So I think so. It depends on the question, right? So if you're trying to find out if they have epicardial ischemia, then heart flow is decent. I won't say excellent. But then if your question beyond that is if they have CMD, then the CT can answer that. So because a lot of people with CMD with microvascular angina are going to have some epicardial disease. It's a misconception that people with microvascular angina have clean coronaries. Most of these people have some atherosclerosis. It depends on what you're saying. If you still think they have microvascular angina, then yes, pursue either an MR or PET or whatever. Once your FFR is negative. That's what I think.
Yeah, I think that's logical. And I can tell you at Utah, anyone over, I think their policy is anyone over 50%, we can just get sent off. And as long as their insurance will pay for it, the university's fine with it. So we send a moderate number off. Not a single heart flow has come back that's changed in one of my clinical reads. So I've been using that to help calibrate my eye. And so far I haven't gone home feeling like I screwed up. But I think the thing about heart flow is you don't have to do another test. You basically send off. So, and you know, now the turnarounds, I think they're working towards on-site software, but the turnaround is like 4 hours during daylight hours. So you can get an answer pretty darn quick. You can't even order a stress test in that kind of time span. So there are times where the inpatient will use it, inpatient, not inpatient. But bottom line is, it's approved. It works reasonably well. It won't answer the microvascular disease issues.
Let's talk about the non-invasive testing modalities. How does this correlate the CFR estimation for all these modalities? How does it correlate with the invasive CFR that we do in the cath lab? And then do you think like for the CFR values, should we account for like age and gender? Because like for young, otherwise healthy male, I mean, CFR of 2 is not necessarily normal. Contrast that with an elderly patient who has a lot of comorbidities and, and an abnormal metabolic profile, maybe 2 is sufficiently acceptable.
Yeah, no, excellent points. If there was age-related normal values, I would have shown that, but I don't think those exist for PET or MR right now. For correlation against, there's a lot of data against FFR, a little bit of data against IMR. And generally speaking, for at least achieving reasonable diagnostic statistics at the thresholds of 0.75 or 0.8 for FFR, PET and MR perform very well. But that's there. There's a lot of work out of Glasgow. Another one of my fellows, he was an interventional cardiologist and spent 2 years at the NIH working with Robert Letterman, one of the interventional cardiologists, and a year in my lab learning MR. So he got an MR scanner next to the cath lab, and he was doing invasive measures and quantitative MR perfusion in patients. And so they did a lot of work with microvascular disease, and those correlations are reasonable as well. When I talked to him, he says there's as many problems on MR as in the cath lab. They're tough measurements, and not everyone can do them. So it's definitely a messy world.